The future of healthcare isn't a distant possibility. It's rapidly approaching. But are we ready for it? As my co-host likes to say, this is serious business. With America's aging population growing fast, the demand for care is skyrocketing. Seniors and their loved ones want choices that honor dignity and independence. As our community knows well, home care is a vital part of the solution. So why isn't it more accessible? Workforce shortages, inadequate reimbursement rates, and outdated policies stand in the way. The future of aging isn't just about care, it's about choice. Are we ready to meet the moment? We better be. Let's find out. Okay, so we're going to be talking about the reality of aging in America. And we often hear this talked about as a future crisis. But what we want people to understand is that crisis in the future is actually here right now. So I was thinking we could set the scene by talking about some of the numbers right now, like what is the aging population looking like? What do we look to in the future? And what's the state of play for aging in America currently? And why do we need to start worrying about this in the present?
Elyssa, I'm so happy you brought this up. My background's in geriatric medicine. I don't go anywhere without thinking about demographics and talking about demographics, the numbers. A lot of press is given to the population that's growing age 65 and older. We know that by 2050, we're going to have over 80 million Americans 65 and older. And I've got to say, it's a big number, but it doesn't get me that excited or that worried. What does wake me up and make me concerned and a need for us to focus on planning is the population 85 and older. This, the oldest of the old. We're actually going to see from 2020 to 2060 a tripling of the number of people 85 and older. We're going to have over 19 million people in our country 85 and older. Actually, globally, I think it's going to quadruple over the same time period. So this is like a global phenomenon. And when we're talking about the population of oldest old, it's different. That certainly there's so much hope for vibrancy and healthy aging and active, wonderful aging. But also when we get into that population 85 and older, there's more likely to be challenges around needing help with the basics of life, caregiving needs. And are we ready for it? I'm concerned we're not.
Yeah, that's really interesting that you bring that up. I think often that 65 and older stat is used. And again, like you said, it's a good one. 65 is the new 45. So it is important for us to be thinking about that 85 and older population. And I think the stat is that only 33% report not having disabilities right now in that age cohort, which is a staggering number and likely still an underestimate. So there's definitely a lot of work for us to do. How about the way that we're handling those numbers now? Are healthcare systems, are hospitals able to handle that influx of the aging population, or are there strains on the system that we should be addressing?
It's already a challenge. Families are under incredible stress. If we look at the healthcare system, again, we're going to talk a lot about healthcare, and it's important. It's at the center of how we meet the needs of an aging population. At the same time, it'd be better if folks didn't have to use the healthcare system. And there's so much that can be done in terms of wellness and prevention. And I hope that we get to chat about some of that. But the health system already is under incredible strain. Okay, we actually, just in the last few weeks, we saw one of the more famous hospital systems in the country, the Mass General Brigham Health System, announced that they had, over $50 million quarterly loss, operating loss. A lot of that because they're struggling to get people out of the hospital because they don't have access to post-acute care. Like there's not enough home health or nursing facility beds available to get people to move through the system. That has, if people can't transition out of a hospital, what happens to the new folks that need hospital care? And we've heard stories of people, older people backed up in emergency rooms, staying a day, 2-3 days on a bed in a hallway in an emergency room. That's not an age-friendly situation. Home health, the National Alliance for Care at Home, which is our professional home and our passion. We have members all over the country doing home health services. They are short-staffed in many places already, just today, before we have this continuing shift of our demographics. And so there are times, I think now the number's over a third of the time that somebody's referred for home health out of a hospital and they don't get it.
Wow.
There's a lot of reason to be concerned. Families are under a lot of stress. Family caregivers, they're really the linchpin. When you think about care at home, the kind of what we're so into and so much trying to lead the way on. Care at home often is just about buttressing family caregivers. It's about lifting up family caregivers, and they've got their own work needs and children that they're juggling, and maybe their own health concerns. And so we're there to help support family caregivers, and they're already under a lot of stress. What's going to happen 10, 20 years from now if we don't get our act together and plan and prepare?
I do want to get to what good aging can look like, but I want to double click on something that you said first around home health referrals going unmet. So what's concerning about that? Why should we be worried? I mean, I know that not only is that bad for patients and families, that increases mortality. Can you talk a bit more about what that looks like when a patient gets turned away or isn't able to access the care that they need?
You said it, really. I think first and foremost, it's a life and death issue. All right. So if somebody has been in a hospital, older person, again, we were talking about that 85 plus population, maybe a person in their 80s who's had a serious infection like a pneumonia, or maybe, unfortunately, we see falls and hip fractures and need for surgical repair, and whatever that problem is. This is a very high risk situation. Okay, people don't just go in a hospital, willy nilly, like just to spend a couple days. Okay, you've got to be in a pretty sick and vulnerable circumstance to end up in a hospital in 2025, and they go home. And the needs aren't gone, right? The risks aren't gone. Yes, things have stabilized a bit, but there may be a surgical wound that still has needs to heal. It may still be at risk for infection. There may be new medications that need to be monitored for side effects, and also to make sure that they're working and having their intended impact. There's might be new caregiving needs, and so person comes home and they don't get that follow-up care. They could have a medical complication that gets missed and they don't realize it till too late, and something terrible happens. We know mortality rates appear higher for people that don't get home health when it's prescribed. So mortality, safety, and then there's also, it's wasteful if things fall through the cracks and the person has to go back to the hospital. It's a horrible experience for them, and it's costly for the system. Yeah. There's a whole other issue on aging that we haven't touched on yet. That's just a major implication is, what does this demographic shift mean for our public programs like Medicare, Medicaid, families out-of-pocket expenses? And these programs, we can't afford to have people, needing, tens of thousands of dollars in unnecessary hospital care just because they didn't get the very affordable and simple follow-up care at home. Yeah. We've got to solve those problems better than what we're doing now.
Yeah, you're going to hear us talk a lot about that. I mean, that win-win situation where the patients and families prefer the care and we save the system money. And that's true kind of across the care at home continuum that we talk about. So I think that's really important. We've done a lot of doom and gloom. Things are bad. They're going to get worse. Great. But what about what imagined world could look like? So what does healthy aging look like? What are some of the things that people should keep in mind, that the system should be set up for to help support?
One of the things I like to think about on this topic is the age-friendly framework that the Institute for Healthcare Improvement and the John Hartford Foundation have really championed. Now, they actually set this up looking initially at hospitals and what does sort of an age-friendly hospital look like. But I actually think it goes across settings and venues. They refer to the 4 M's for age-friendly, which the M's being mobility, mentation or thinking, medication, and probably the most important one of all, what matters most. And I think that if we focus on these things as a country, as communities, that we're going to be in a much better position for aging, right? People, individuals, families, think about what matters most at your age. Maybe it's being able to stay at home. Maybe it's being close to family. Maybe it's continuing a treasured hobby or activity or something faith related. Mobility is crucial at every age, we have got to keep moving. It's use it or lose it. We've got to make sure that our communities, that our families, that we are getting going. I love the fact that, the whole world, with the iPhones and the devices and the watches, like you can track, like I get these alerts all the time, like you are a lazy, it's horrible. Like you get my thing, like actually, like the phone says, is it possible for a human to move less than you? Like, it's like like
you got work to do.
But you know what? If I pay attention and get moving, then maybe my trajectory will be different. Like maybe what I can do, like what you can do when you're, what am I? I don't even want to share this. I'm about to be 50 in a month here. And but what you can do when you're 50 or 60 physically has implications for what you can do as you age, right? You're on a trajectory, right? If you're already struggling, and so movement, like even, not to digress, but like, at the hospital, and we're working at the hospital, or, there's stairs, like you can use them. It actually, you burn some calories, you use your muscles, and there's some benefit, not just to hopping in the elevator or sitting down. We've got to keep moving. Mentation, mind stuff, big deal, right? And it's not just about like how sharp we are, like doing, puzzles and trying to, can we remember vocabulary words or test ourselves? It's not that's important, being sort of sharp from a memory and critical thinking standpoint, but also what's our mental health? How are we doing things to support our happiness, reduce anxiety, lower stress? Those are critical issues across the board, whether we're talking about folks in our 30s and 40s or in our 70s and 80s. Critical issues to have a healthier population, certainly healthy aging.
Okay, that's painting a good picture for us about what it could look like. I think it would be really valuable for us to also talk about what kind of we've seen ourselves. I know you've been in the home delivering care, seeing the difference that home-based care can make. I know you've had some personal experience. I have also. I think bringing it to life, like what it looks like when patients finally get the preference that they want for care and they have the support they need, what a transformative role that plays in their life. And to your point about mental health and the mental health of the caregivers and the families, that's something I experienced firsthand. So I'm curious if you want to share either about your time providing care or receiving care for your family, and I'm happy to share a bit about my story too.
Yeah, and I can't wait to hear some of your perspectives, Elyssa. I was really lucky when I started my medical career. I got the chance to actually just go out and do a lot of home visits. Actually made thousands of house calls, like home-based medical practice. I don't know what it was like when I was doing my training. I think they were like, we're not sure what we're going to do with this guy. And the department chair, George Kakano, who was actually the dean at Central Michigan's medical school now, but George said, Steve, we really want to reinvigorate physician home visits. And we think, you'd be good at trying this. It wasn't on the radar. Got out into the community, seeing people in their home, and I was blown away. Just one, the gratitude. So there are so many families and caregivers that are desperate for help. Okay. They want to keep going at home. They don't want to have to move out of their own homes or move their family members out, but they need a little bit of help. And so the gratitude is incredible. And then what you learn about people, you see, I had been used to seeing patients in an office, like a sterile office setting. There's like the bed with that paper. Is there anything more uncomfortable than that paper we put on the yeah, like you sit on that and it's like it's itchy but it keeps the table clean. You see people in their home. You've got the pictures on the wall that kind of show, and sometimes their family story or things about their culture, and also practical things like, is there food? How are their medicines organized? Are they in a safe environment? Everything from fall hazards to lighting to, is it what's the air quality? People with respiratory disease, and you've sometimes got homes where there's mold and dust and bad air quality. So you learn a lot about the person, and it helps you provide better care. So you get that great view of people. They're often grateful for the help at home. You can help them stay at home, which is often life-changing for them and their families, there's a good bond. Like our caregivers, you know this because you've been so involved in the hospice movement, and you've been, hospice is mostly a home-based care model, and it's so crucial for care at home at the end of life.
Yeah.
And you've seen this. It just the connection that the caregivers, the nurses or the chaplains, the social workers, the aides in particular. I mean, we're going to talk a lot about aides. We probably should spend like an hour or more talking about home health aides, but they bond with people. They sit next to them on their couch, across from at their kitchen table. Often, it's warm. It shows people when we take the care to the home, it shows people that they're worth being known and valued. Yeah. It's a humanistic thing. It's an act of humility. I think when we think about an aging country, we think about aging population. To me, synonymous with getting that right is getting care at home right.
That was a beautiful way to talk about it. I think that showing them that you care and you value them, meeting them on their own turf is one of the shining parts about home-based care. I've heard you tell a story before about visiting a patient who had been readmitted to the hospital or gone to the hospital multiple times because of stomach issues. And it turned out that she had poor vision and was eating moldy food. I mean, that never occurred to me before I came into the home-based care space, that could be something that's costing the system money, obviously causing the patient pain. And all it took is one quick trip to the home for you to see, oh, this is an easy fix. We can make it better for everyone. I think that's transformational and really simple things that we already know how to do. We should be doing. And you spoke to it. I do have more experience further along in the care continuum with hospice and palliative care. I've worked in this space for a while now, but I also had a personal experience. When I was a kid, my dad was diagnosed with cancer, and he battled. I use that word really intentionally, which I don't like the use of the word battle in a clinical context often, but that's what he was doing, putting himself through pain because he wanted to see me grow up. He wanted to spend time with my mom. And then finally, he came home on hospice care after 6 years. And those 6-ish months on hospice care were the best time period in the entire 6 years of his illness because we created memories. I got in bed with him in his gurney in our home, and we studied Latin. I don't know why I took Latin, doesn't serve me now, but we studied Latin together. I have those memories. I have memories of him. It was Thanksgiving and he couldn't eat. He had a bag to feed himself, a feeding bag. And we blended up like some distorted version of my Nana's pecan pie and tried to give him some of that just to be part of those memories. And I'm still talking about them to this day, over 10 years later. So that's what brought me into the hospice space. And I can't begin to explain. The stats are important. The data is important. But the stories that people share and that you learn and that you experience in the field in home care and hospice are really the reason why I'm here, why we're here pushing forward. So I think it's really important that people hear that and know that the real impact that home-based care can have. So it's an honor to be able to help push forward the hospice movement. And I love that you said movement because it really is a movement. Care at home, it's a movement. And we are at the forefront pushing forward on behalf of the professionals and the patients and families who need us at the National Alliance for Care at Home.
Absolutely. It is a movement. And thank you for sharing about, your journey with your dad. Sorry for that suffering and all of the challenges. I can't imagine just hearing a little bit, but at the same time, how important and special to get that part of life, right? To get that opportunity to love and connect and to be together. And one of the things I've noticed, I got certified as a hospice and palliative medicine physician and have spent a lot of my career in hospice. And it doesn't make for great, dinner party conversation sometimes, right?
I know that.
So sometimes you people say, well, what do what do you do for a living? Or, Steve, good to meet you. And then, some folks are, I work in investments or, we do law or whatever it is. And then I turn to, the medical world and sometimes the hospice, and people kind of look at their shoes and, they're not sure what to say.
It must be so hard.
And everything so hard and so difficult. And what I try to do, because it's true, is tell people that you know what? It's a lot more about living than dying. Hospice is a lot more about life than it is about death. And, your time with your father, just a reminder for me of that is that what we're doing in hospice, what we're doing in care at home broadly, when we're helping people that have serious challenges, whether it's cancer or neurological diseases like Alzheimer's disease or Parkinson's disease or other, problems, people that have serious problems, how do they keep living, right? How do you get the most out of what you got left, right? And we don't always know what exactly we've got left. And sometimes it comes faster than we think. And sometimes people are able to survive longer and get a longer benefit. But the hospice in care at home helps people stay part of the community, part of their families. There was an old saying, I'm trying to remember, I think the quote was attributed to Knight Steele, who was one of the geriatricians at Hackensack many moons ago, that and I'm paraphrasing the quote, but basically the idea was that hospitalization is essentially somebody being discharged from the community, and that we've got to do our best as a country, in our families and communities. We got to do our best to help people stay in the community, stay with their families. Of course, sometimes it doesn't happen, and we have to tip our hats. There are some incredible facilities, institutions, whether those are long-term care providers, hospice inpatient services, that help people when there just isn't an option. Right. But for so many people, it is, if we take the effort, if we have the creativity, if we set up the systems and care models, we can help more people go home and stay home and share that experience with their loved ones. And I'm so happy, not that your dad had such a battle, and that I can imagine the pain and the trauma of all that. But that you were able to get those moments, and you were able to share that time together.
This show is brought to you by the National Alliance for Care at Home, because every person deserves access to high-quality care where they feel safest, at home. The Alliance is working to advance policies, support caregivers, and shape the future of home-based care. Visit allianceforcareathome.org to learn how we're driving change and how you can get involved. All right, let's get back to the show. Okay, for this next segment, we're going to do a little bit of myth and truth about aging in America. So I'm going to read out a statement, and then you're going to tell me, is it a myth or is it true? And then we'll talk a little bit about why. Ready?
Sure thing.
Okay, so statement number 1. Aging at home costs more than facility care. That should be an easy one.
That's a myth. We know across many studies and many types of care that home-based care is more cost-effective for the system. Whether we're talking about hospice care at home, and we know with the NORC University of Chicago evaluation that in many scenarios, hospice care will save Medicare money and do a great job meeting patient and family needs. We look at acute care at home demonstration models. Even hospital-like care at home can save the system money. Home health as an alternative to institutional rehabilitation in post-acute recovery is less expensive. Family care can often be less expensive at home. Usually when you provide family caregiving and home health agency or aid services at home, you're supplementing family care, not having to pay for the entire cost of an institution.
Statement number 2. Telehealth and expanding care technologies like AI can replace in-person care for most aging patients.
That I'm going to say is a myth, but there's a chance that I'm going to regret having this on tape, because I think that in-home direct care is of critical importance. There's just people's basic needs, personal care, things like bathing, dressing, keeping the house in order, meals. These require in-home help. That said, technology is changing the face of what can be done at home, and it'll continue to evolve. Check-ins via video conferencing,
Right.
remote monitoring, making sure that people's whether it's vital signs or medication management is being tracked, and that things don't fall through the cracks. Technology will continue to play an increasing role, but there's nothing that is replacing that loving and skillful hands-on care.
I think we can stand proud of that answer. It will supplement care, but I really hope it never replaces human touch. That might be a little bit of a scary reality, but certainly a lot of support. Okay, statement number 3. Family caregivers are the backbone of the home care system.
Absolutely true. So family caregivers are doing the bulk of care. I think I've seen estimates that it's like over $300 billion worth of care that family caregivers are providing. We say family, it's actually typically daughter, spouse care in many instances, adult children, some non-family relatives and or neighbors and friends are providing these services. They're doing everything from help with the basics of life, again, dressing, bathing, mobilization, transportation, meals, help with medical care, organizing and responding to doctor's appointments. They're doing it all, and they should be at the center of any strategy that we have for aging in America.
I couldn't agree more. I think we'll talk about this quite a bit, but family caregivers often put themselves second to the patient, which of course is necessary in some situations, but it can also mean that they skip out on medical treatment themselves. They end up getting sicker later. I mean, that's really stressing the system. And of course, the toll that it takes on their mental health, which I know we talked about a little bit earlier. So, family caregivers are the backbone of the system, but we need to better support them. And I know that's something that we're talking about at the Alliance. Last statement. Most seniors prefer to age at home.
It's a fact. It's the truth. We actually, Harvard School of Public Health just recently did an analysis of older people and their caregivers' preference for post-hospital care, post-acute care. And there's a strong preference for care at home. There's a long history of studies and surveys of people about their preference for aging, and aging in place, aging at home is preferred. It's essential that people have the community supports they need, because aging in the community without help can be isolating and lonely. And we've got to make sure that those resources are there to help people. But the preference of being in the comfort of your home, it's a power thing. It's autonomy and independence to be able to stay in the community where you're comfortable with your family and friends.
I wasn't able to stump you on any of those myths or truths, but I think that was still informational. So thank you for playing that game with me.
Yeah, absolutely.
The future of aging has to change, and we're just getting started. If you want to be a part of more conversations like this with real stories, real solutions, and real talk about the future of care, make sure to subscribe to our YouTube channel. Just search for Who Cares or the National Alliance for Care at Home. Tap that subscribe button and you'll get new episodes, insights, and the latest on how we can reshape care at home together. We're going to do a fun segment next where we talk about a win-win solution, and specifically the home health value-based purchasing model from CMMI and why that was a success for all parties involved. Let's start by talking about what challenge that model was created to try to solve.
Yeah, home health value-based purchasing was designed by Medicare, actually by the Medicare and Medicaid Innovation Center, as a way to incentivize home health providers to get better outcomes, and especially get better outcomes in areas that lead to lower overall Medicare costs, like reducing unnecessary hospitalization, unnecessary emergency room use by proactive home health. So that was basically the idea behind value-based purchasing, and it has risks and rewards, or carrots and sticks, so to speak, because what happens is the providers get paid more if the outcomes are better, and they actually get paid less and are penalized if the outcomes are worse. And so I think the swing right now in the current iteration is 5% either way on their provider payments.
Okay. And what have we seen so far with the performance of that model? Are providers liking it? What are the outcomes like for patients and families? Are we saving the system money?
Home health value-based purchasing has largely been a success story. Okay, this has been a success story in that what's happened is that the model that incentivizes better care has led to improved quality measures, things like medication management, functional improvement, but also has saved money because of lower hospitalization rates, lower rates of emergency room utilization. And so actually, I think it's saved to the tune of a few $100 million a year in the Medicare system by setting this up. We always have to be there's a side of this that we always need to be mindful of and make sure that the risk adjusters are perfect so that it's not disadvantaging an agency that's serving sicker patients or people that are more socially vulnerable.
That's really exciting to hear about, especially when you're able to really hone in on those indicators or outcomes that actually drive high quality care and align the incentives, as you mentioned. It's promising. I know we often talk a lot about the fact that we're already providing value-based care in home health and hospice. Like that's the model as it is, whether or not you have certain terminology attached to it, because we're delivering value for lower cost. So I think to have kind of the models catching up to the way that us in the care at home space think about value and delivering care to patients and families is exciting. Are there any other kind of exciting things that you're looking to in value-based care in home health?
Well, I can tell you what I'd be really excited about is that as all our home health agencies across the country are doing this great work and saving the system money, that some of those monies get reinvested back into home health so that they can recruit more talent. So we have less of these referrals go unresolved, that we can make sure that there's career development opportunities for that workforce in home health, that the home health has the best available technology. So the folks making the policies would ask me, would I tell them, yeah, keep going with this model, but make sure those savings get reinvested in home health so that for years to come, we've got a strong and vibrant home health option within Medicare.
That would truly be a win-win-win-win.
Absolutely.
Remember, better care starts with choice. Investing in home care strengthens families. And the future of aging is a future we build together. Care at home will impact us all. Let's shape the future together.